Hello, everyone. My name is Ivy Wogu, and I am the PGY2 Ambulatory Care Pharmacy Resident at Cone Health. In my section, Part 2, we'll be discussing insulin therapies, hypoglycemia management, and CGMs. Now I will talk about some insulin therapies. Insulin stimulates peripheral glucose uptake primarily by skeletal muscle cells and fat, and by inhibiting glucose production and release by the liver. The main side effects include weight gain and hypoglycemia. Basal insulin, known as long-acting insulin, should be considered if additional A1C lowering is needed in patients already on a GLP-1 agonist, or if a GLP-1 is not appropriate, or if insulin is preferred. The choice of basal insulin should be based on patient-specific considerations, including cost and access. When starting a basal insulin, known as long-acting insulin, it can be started at 10 units per day or 0.1 to 0.2 units per kilogram per day. Titration of insulin should be based on the patient's sugars and risk of hypoglycemia. There are times when we should prioritize adding insulin first. For example, in pregnancy, in patients diagnosed with type 1 diabetes, patients experiencing severe hypoglycemia, especially if they're symptomatic, patients experiencing catabolic features such as extreme weight loss, hypertriglyceridemia, and ketosis, patients with impaired wound healing or severe illness, patients who are refractory to other add-on therapies, and also in type 2 diabetes, after initial glucose toxicity resolves, regimens should be simplified or possibly switched to another agent. Here's a nice graph comparing the duration of action between bolus and basal insulins. As you can see on the left, our bolus insulins have a peak, while our basal insulins further to the right tend not to have a peak. There are many basal insulins available. Some long-acting insulins include Levemir, which has a duration of action of about 12 hours and is usually dosed twice daily. Lantus and Toujeo is usually dosed once daily, and Tresiba is also dosed once daily and has the longest duration of action of 42 hours or more. NPH is an intermediate acting insulin with a duration of action of 10 to 16 hours and can be dosed once or twice daily and is also available over the counter. Bolus includes rapid or short-acting insulins, which are normally dosed with meals. It is recommended to take these 15 to 20 minutes before meals, except for Fias, which should be taken right at mealtime or 20 minutes after a meal. Bolus insulin should not be taken if the patient does not plan to eat. Fiasp is the first and only fast-acting mealtime insulin injection that does not have a pre-meal dosing recommendation. While most fast-acting insulins would need to be dosed 20 minutes before eating to prevent that post-meal spike, Fiasp can be dosed up to 20 minutes after eating and still reduce the post-meal spike in glucose. This is due to its niacinamide component, which increases speed of absorption. It is beneficial in patients who eat low-fat and high-carb diets, children, and pregnant women. Premixed insulin is a mixture of NPH plus rapid or short-acting insulin. They are useful options if cost or insurance are an issue because they are available over the counter and can be a cheaper option for patients. They are typically dosed twice daily with meals and administered 30 to 45 minutes before a meal. Another option of insulins we have available is the U500. This is a concentrated insulin and can be used in patients with insulin resistance or in patients who require high daily U100 insulin requirements. This is usually more than 200 units per day or in patients who have volume challenges. The main concept I want you to grasp from this slide is when switching from insulin or adding to insulin, a GLP-1 or SGLT2, insulin may require a dose reduction, meaning that depending on the units that a patient takes of insulin throughout the day may require a 25 to 50% dose reduction when starting a non-insulin agent. Now I will talk about the different treatments we have available for hypoglycemia management. Lastly, we should educate all of our patients with diabetes on therapies that can cause hypoglycemia and how to manage this. If a patient feels symptoms of hypoglycemia, including shakiness, anxiety, sweating, or lightheadedness, they should test their sugar and eat or drink 15 grams of carb, then recheck their sugar in 15 minutes and repeat the cycle if not recovered. Once recovered, patients should eat a snack that is more substantial to ensure blood glucose stays up, for example, like a sandwich. Injectable glucagon was one of the first products available for glucagon administration for severe hypoglycemia. But now we have other options that are readily available for easy administration. Intranasal and subcutaneous glucagon are now available for use and are easier for patients who are experiencing severe hypoglycemia to administer to themselves. Baqsimi is given intranasally and FDA approved for patients 4 years or older. It can be dosed up to one spray in one nostril every 15 minutes and does not require inhalation. Gvoke is given subcutaneously and is FDA approved for children 2 years or older. It is given into the lower abdomen, outer thigh, or outer upper arm, and it has two different strengths depending on their weight. Now I will briefly talk about continuous glucose monitoring, CGMs. A CGM is a continuous glucose monitor that sticks onto the skin and is a measurement of glucose in the interstitial fluid. It monitors glucose every 1 to 5 minutes via a sensor and displays, records, and transmits glucose data to a reader device or a cell phone. Data can also be sent to a storage center in which the provider and patient have access to review the reports virtually. CGMs are important in diabetes management because they reduce glycemic variability, which refers to the fluctuations in blood glucose levels throughout the day. They also help reduce A1C and increase time spent in target range. It also improves quality of life as patients feel more confident in managing their diabetes. There are two main types of CGMs. The first one is real-time CGM, which data is automatically transmitted continuously to a receiver device or cell phone. It also has automated alarms in which it alerts the patient when sugars are or approaching highs or lows. It also provides a complete glucose profile that records glucose trends and patterns. Some examples include Dexcom and Eversense, which will be discussed later in this presentation. The other type of CGM is the intermittent scan CGM, also known as the flash CGM. This measures glucose levels continuously but requires users to physically scan the sensor to obtain glucose data. Some caveats to flash CGM is that patients must scan the sensor at least every 8 hours in order for the CGM to generate a full 24-hour glycemic report. So in other words, I counsel my patients to scan their sensor at breakfast, lunch, and dinner. There are two types of flash CGM. The first one is Freestyle Libre 14-day, which does not have sugar alarms. And the other one is Freestyle Libre 2.0, which has customizable alarms. Guidelines continue to support the use of CGM in patients with diabetes. The 2022 ADA guidelines recommend both types of CGM devices in patients with multiple daily injections of insulin as a useful tool to lower and maintain A1C, as well as reduce hypoglycemia regardless of type of diabetes and age. The AACE recently released guidelines discussing the use of advanced technology in the management of people with diabetes. They recommend that all patients with diabetes on intensive or less intensive insulin therapy can benefit from CGMs, and that glycemic targets should be individualized based on the patient's health status, comorbidities, and risk of hypoglycemia. Time in range is a useful metric of glycemic control and correlates well with the A1C in most studies. It is the percentage of time the patient's blood glucose is in the target range of 70 to 180. So, time below range indicates sugars below 70, and time above range indicates sugars above 180. This is a valuable percentage because it compares glucose fluctuations for any amount of time and is likely to capture the impact of acute interventions. For patients with type 1 and type 2 diabetes, the goal time and range should be greater than 70%. On average, a TIR of 70% corresponds with an A1C of about 7%. We want the time in hypo and hyperglycemia to be as low as possible for adequate glycemic control. The Dexcom G6 is relatively small and easy to apply. It is approved for children 2 years and older and can be used for up to 10 days. It measures sugars every 5 minutes. However, the sensor must be within 20 feet of the reader to display the readings. The transmitter is reusable for 3 months, and the device has customizable alarms. A unique feature of Dexcom is that it is one of the few CGMs that can pair with insulin pumps. It is also water resistant and has the Dexcom Follow app, which allows users to have up to 10 people following their glucose readings. This is important for family members, such as parents or siblings, as they can have an active role in the patient's diabetes management. The Freestyle Libre 2.0 is an upgraded version of the Libre 14-day. It is a flash CGM that requires users to scan the sensor to obtain glucose readings. Unlike the 14-day, the 2.0 is approved for ages 4 and up and measures blood glucose every minute or when directly scanned. But users must still scan every 8 hours to avoid data gaps. So I tell my patients to scan their sensor at breakfast, lunch, and dinner. I also remind patients that the sensor must be within 4 to 5 feet of the reader device. Additionally, it has optional custom alerts and has the Libre Link Up app with the follow user option. Some concerns that we tell our patients to be aware of are that CGMs are not recommended with MRI, CT scan, or X-rays, as well as with pregnancy or dialysis. In particular, patients using Dexcom should avoid sunscreen or insect repellent around the site of scanner placement, as this can cause the plastic in the Dexcom to crack. There are some drugs that also interfere with the accuracy of glucose levels with CGMs, which we will talk about next. With Dexcom, taking 4 grams or more of Tylenol daily or taking hydroxyurea can cause glucose levels to appear higher than they are. For Freestyle Libre, high levels of ascorbic acid or aspirin, hydroxyurea, and severe dehydration may lead to inaccurate results. Here listed on the slide is populations who may benefit from CGM use. Pregnant patients may likely benefit, but it gets confusing because pregnancy is listed as a contraindication by CGM manufacturers. This is because it was not studied in the pregnant population. And that wraps up my section on insulin therapies, hypoglycemia management, and CGMs.